Welcome to our second and last video on acid-base disorders. Let's begin. In this lecture, we'll discuss respiratory acidosis and respiratory alkalosis. Let's start with respiratory acidosis. We'll discuss definition, causes, clinical presentation, diagnosis, and management of respiratory acidosis. Respiratory acidosis is an acid-base disturbance marked by arterial pH less than 7.35 and an increased partial pressure of carbon dioxide. Here we have the possible causes of respiratory acidosis. Chronic lung diseases such as chronic obstructive pulmonary disease can cause carbon dioxide retention and therefore respiratory acidosis. The same mechanism explains the respiratory acidosis in the setting of acute lung diseases like acute respiratory distress syndrome. Airway obstruction will interfere with carbon dioxide exhalation. Carbon dioxide retention will lower the serum pH. Any medication depressing the medullary respiratory center and the respiratory rate can result in respiratory acidosis. Such medications include opioids and other sedatives. Additionally, conditions accompanied by weakened respiratory muscles interfere with carbon dioxide exhalation and therefore predispose the patient to respiratory acidosis. These conditions include myasthenia gravis, poliomyelitis, Guillain-Barré syndrome, and so on. Finally, restricted lung expansion can prevent carbon dioxide exhalation, resulting in respiratory acidosis. For example, patients with ankylosing spondylitis have costovertebral and costosternal ankylosis. Therefore, their lung expansion is limited, and they might present with respiratory acidosis. This is a posterior-anterior and lateral chest X-ray image of the patient with chronic obstructive pulmonary disease. Please take notice of the hyperinflated and hyperlucent lungs, along with the flattened diaphragm due to air trapping. Here we have the chest X-ray image of a patient with acute respiratory distress syndrome. Hopefully you can appreciate diffuse bilateral pulmonary infiltrates. Most symptoms of respiratory acidosis depend on the specific cause of this acid-base disorder. However, nonspecific general findings include hypoventilation as the primary disturbance and the altered mental status due to CO2 retention. Let's talk about the arterial blood gas findings in respiratory acidosis. Arterial pH is less than 7.35, and partial pressure of carbon dioxide is more than 45. Serum bicarbonate levels are increased due to slow increase in renal bicarbonate reabsorption. Generally, renal compensation is slower than respiratory compensation because it takes time to modify the renal excretion of bicarbonate ions. Urine drug screen can also be performed in a patient with respiratory acidosis to screen for opioid intoxication. Chest X-ray will help us diagnose the acute and chronic pulmonary causes of respiratory acidosis. Let's try a question. A 36-year-old man comes to the physician due to low back pain for 6 months. He finds it difficult to bend forward. The patient also complains of shortness of breath and vision problems in his left eye. The physical exam reveals kyphosis and erythema and tearing of the left eye. His laboratory findings are significant for respiratory acidosis with renal compensation. What is the most likely pathogenesis of this patient's lab findings? This relatively young patient presents with low back pain. He also complains of shortness of breath and vision problems in his left eye. The physical exam reveals kyphosis and erythema and tearing of the left eye. All these findings are consistent with ankylosing spondylitis complicated by uveitis. This patient's lab findings are significant for respiratory acidosis. Respiratory acidosis in the setting of ankylosing spondylitis is due to costovertebral and costosternal joint fusion. Therefore, the rib cage cannot move freely during respiration, and the patient has carbon dioxide retention causing respiratory acidosis. Patients with respiratory acidosis are given oxygen to maintain sufficient oxygenation. Intubation is needed only in cases of severe respiratory depression. Otherwise, the management is specific to the cause of this acid-base disorder. For example, we can administer naloxone to the patient suspected of having opioid intoxication. Lastly, we'll talk about respiratory alkalosis. We will discuss definition, causes, clinical presentation, diagnosis, and management of respiratory alkalosis. Respiratory alkalosis is an acid-base disorder characterized by arterial pH of more than 7.45 and decreased partial pressure of carbon dioxide. Respiratory alkalosis can be caused by multiple different conditions. However, all these conditions induce hyperventilation, and this is how they cause respiratory alkalosis. First, pulmonary embolism induces hyperventilation and exhalation of excessive carbon dioxide. Blowing off of carbon dioxide results in respiratory alkalosis. Pregnancy can also induce this acid-base disorder. Pregnancy-induced increase in serum progesterone levels stimulates medullary respiratory center and causes hyperventilation. High altitude is a common cause of respiratory alkalosis. Relative oxygen deficiency at high altitude stimulates peripheral chemoreceptors, and the patient starts hyperventilating. Hyperventilation eliminates excessive carbon dioxide. Salicylate toxicity can also cause respiratory alkalosis, especially in the early phase, because aspirin directly stimulates medullary respiratory center. Later, salicylates cause high anion gap metabolic acidosis. Therefore, aspirin toxicity can result in mixed acid-base disorder. Finally, anxiety and panic attack can cause this acid-base disorder due to hyperventilation. Now let's talk about the clinical presentation of respiratory alkalosis. Most symptoms of respiratory alkalosis depend on the specific cause. For example, if this acid-base disorder is caused by pulmonary embolism, then the patient might experience chest pain. Nonspecific general findings include hyperventilation as the primary disturbance, shortness of breath, and altered mental status. Let's talk about the arterial blood gas findings in respiratory alkalosis. Arterial pH is more than 7.45, and partial pressures of carbon dioxide is less than 33. Serum bicarbonate levels are decreased due to a slow decline in renal bicarbonate reabsorption. D-dimer or CT angiography can be performed in the patient with respiratory alkalosis to rule out pulmonary embolism. If stimulant intoxication is suspected, we can perform the urine drug screen. Finally, urine pregnancy tests can help us diagnose the pregnancy-induced hyperventilation. Management of respiratory alkalosis is mostly supportive. We can administer sedative medications like benzodiazepines to calm the patient down. Breathing in the bag will cause inhalation of the patient's CO2, and it will compensate for the lost CO2. Otherwise, management is cause-specific. For example, we should give anticoagulants to the patient with pulmonary embolism-induced respiratory alkalosis. Here we see Davenport diagram of acid-base disorders. Let's freshen up what we already discussed. The x-axis displays the different arterial blood pH values, while y-axis displays arterial plasma bicarbonate values. In general, anything to the right of 7.4 is considered alkalosis, while anything to the left of 7.4 is considered acidosis. pH more than 7.4 with high bicarbonate and high partial pressure of carbon dioxide corresponds to metabolic alkalosis. In contrast, pH more than 7.4 with low bicarbonate and low partial pressure of carbon dioxide is respiratory alkalosis. Anything in between these two conditions is mixed alkalosis. pH less than 7.4 with high bicarbonate and high partial pressure of carbon dioxide corresponds to respiratory acidosis. In contrast, pH less than 7.4 with low bicarbonate and low partial pressure of carbon dioxide corresponds to metabolic acidosis. Anything in between these conditions is mixed acidosis. Here we have the algorithm showing all the acid-base disorders and their potential causes. Pause the video to take a moment to consider this algorithm. Let's end our lecture with a question. A 24-year-old woman is brought to the emergency department due to agitation and tremor for the past 15 minutes. The patient complains of palpitations and sweating profusely. There were no preceding events before the onset of her symptoms. ECG reveals sinus tachycardia. The patient is accompanied by her boyfriend, who says that this is her third episode with similar symptoms in the past year. The patient's vital signs include a temperature of 36 degrees Celsius, blood pressure of 125/80, heart rate of 110 beats per minute, and respiratory rate of 27. Which of the following laboratory findings is expected in this patient? A. pH of 7.5, PCO2 of 30, HCO3 of 24. B. pH of 7.48, PCO2 of 47, HCO3 of 34. C. pH of 7.2, PCO2 of 50, HCO3 of 25. D. pH of 7.3, PCO2 of 29, HCO3 of 14. This patient presents with agitation and tremor for the past 15 minutes. The patient complains of palpitations and is sweating profusely. There were no preceding events before the onset of her symptoms. ECG reveals sinus tachycardia. According to her boyfriend, this is her third episode with similar symptoms for the past year. All these findings suggest the diagnosis of a panic disorder. The patient is hyperventilating, evidenced by her respiratory rate of 27. Hyperventilation causes excessive loss of carbon dioxide, leading to respiratory alkalosis. The arterial blood gas pattern, which best corresponds to the respiratory alkalosis, is option A. The pH is high, the partial pressure of CO2 is low. The bicarbonate concentration is normal because 15 minutes of hyperventilation is an insufficient time for renal compensation. So the correct answer is option A. Here is a slide reminding us of the diagnosis of respiratory alkalosis. Let's discuss why other options are incorrect. Option B corresponds to metabolic rather than respiratory alkalosis because pH and bicarbonate are both high. Option C corresponds to respiratory acidosis. Hyperventilation causes respiratory alkalosis rather than acidosis. Finally, option D corresponds to metabolic acidosis. And that concludes our lecture on respiratory acidosis and alkalosis.